There we go. All right, we're official now. So Heath Village is a nonprofit, non-denominational community, and we have been around for nearly 60 years. We were founded in 1966, so a big celebration will be occurring in a couple of years. We are very proud to be one of the oldest retirement communities in the state. And we're also actually welcoming second generation residents, which is just a wonderful aspect of the community. So we are a full service retirement community. We offer all levels of living. We have independent living. We have modified levels of assisted living, and we also have residential health care. Excuse me. If you do require more assistance than what these levels of care can provide you, we do also have the Meadows, which is our facility that offers long-term, short-term care, respite care, rehabilitation, nursing, and then so you can actually age in place with us at Heath Village through all those levels of care. So our thought is when you move to Heath Village, that you'll be staying with us for the remainder of your years together. So that's just a brief overview. I will be including our brochure in the email, our schedule of fees, any other contact information. You can just reach out to me, and I will include some of our promotional flyers for all of our upcoming events, virtual and in person, that are headed down the road. We hope that you can join us. All right, so now I'm going to hand it over to Chris Kellogg. We're very proud to work with Chris here on the Conversation Project, the Conversation of Your Life seminar. Chris is an aging life care professional, and he's the COO of Nightingale, New Jersey. Chris, if you want to share your screen.
Oh. Okay. Ta-da! Do you see the background? All right. Woo! Off to a good start. All right, everyone. Good morning, and thank you so much, Kara, for the opportunity, and again, Melissa, for letting me come out and speak. My name is Chris Kellogg. I'm a licensed social worker, have been for the last 20 years. My background is exclusively on geriatrics. I earned my master's at Boston University with a concentration in geriatrics and the recipient of the Lewis Lawley Excellence in Gerontological Research. I started Nightingale, New Jersey, going on 8 years ago with my business partner, Kelly, who she and I have known each other for years and years before, working at a nursing home. And the reason why we did this was we were frustrated with the system that there's so much cookie cutter, you have to be able to fill in the blanks. And our role is people deserve better. And instead of saying, what if, why not say, why not, and make the system work? We do a lot of different education programs throughout the state, but this is one that really is one of the hardest and one that I hold most near and dear to me. And we're going to talk about a gamut of different hard conversations. And I'm going to roll through this as fast as I possibly can, because essentially there could be easily 5 different programs that could be an hour long. So we're going to just touch the tip of the iceberg on all of these. Today's purpose is not to encourage you or discourage you about choosing a certain path. All of us have different wishes, hopes, and expectations. There's no universality of what someone's preference of end of life is. The one thing that is most important that we need to understand is by sometimes not talking about things that are uncomfortable, we can't act. We can't enable people that we love, we trust, and we think they know what we want, but they may not know. They may not have the tools to be able to do what we want them to. You know, we go through life, and I say we have an invisible toolkit by our sides. The more we're able to absorb, learn, educate ourselves on, the better we're going to be as far as being an informed healthcare consumer. And that's what I want to really be able to bring here today. I am that guy, and I'm going to give homework to everyone right off the bat. The first thing I'm going to ask is, once this is done, sit down at your home and take out a notepad. On that piece of paper, write down, what is your single sentence of your definition of your quality of life? What is the thing that brings you joy? What is the thing that, makes you want to get out of bed on those cold, rainy days that really you just want to pull the blanket up over your head? That's awfully hard to be able to do, but that is one of the guiding principles that we really need to make sure that our family and our physicians know what that goal is, so they can foster us and support us. Because sometimes by not sharing what's important to us, some decisions can be made that are opposite of what we want. So it's better to be redundant than surprised. When are we ever going to consider ourselves old? That's a rhetorical trick question. We never will. We will never consider ourselves old. There is a multi-billion-dollar industry out there that sells cover-up, age-reducing lines, testosterone pill, Botox, to try to make us look younger than we really are. We plan to fall in love, hope to fall in love, get married, have children, save for our children's future to be able to have them have an education. We don't plan to get old. What we need to be able to do is continue to plan and educate them. Time stops for no one. The technology, like what we talked about before we officially started, continues to leapfrog. Some of the things that is basic medicine right now, having a thermometer held over somebody's forehead, I remember looking at Star Trek, thinking, do, 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 do. And that's daily medicine right now. The question that we need to ask, because we do have more control over what's important to us than what we think we do working with our physicians, is just because technology has leapfrogged, is it really beneficial? Are we trading in longevity versus quality of life? It was Abraham Lincoln who shared, it's not the number of years that matter, it's the amount of life in those years that count. Again, we're all on our independent journey. We need to drive our healthcare. And for us to be able to do that, we need to be able to understand and accept things. Again, age stops for no one. As we age, our physical bodies change. Our heart doesn't pump quite as well. Our kidneys are less effective. Our vision changes. How many of us are walking around with glasses? We need to be able to adapt to maintain. Oftentimes we're able to do the things that we always have, but sometimes it just takes more work. Hearing deficits, we have our hearing aids. We need to make sure that if we start seeing these changes, we're proactive about that. I hear a lot with cognitive changes. It is common as we age that sometimes we think on our feet slower. Why is that? Sometimes it's hearing deficits. If you have a hearing deficit and we're not actively having that treated, that is giving you 3 times the greater likelihood of developing mild cognitive impairment early. It makes a difference. Our mind is just like our biceps and our legs. If we're not able to hear things, we're not going to actively be able to effectively engage in conversations. We got sick, it stayed in bed for 3 days. I'm going to be moving a lot slower. Our bodies atrophy quickly. Our mind's the same way. If we start seeing changes, we need to act, talk to our doctor. Sometimes these changes, again, are because of hearing deficits, vitamin deficiencies, urinary tract infections, medication mismanagement, not taking the right med at the right time, or having the chemistry, what worked before isn't working now, or God forbid there's a fall. What's not normal aging is not having the ability to process things that we once have. If we start seeing changes in ourselves or our loved ones, it's important we say time out. We need to be able to get in front of our doctors, because our doctors are going to be able to help us do many more interventions earlier on, to be able to give the options of what's most important to us. And a lot of times these chronic things that we see are because of chronic diseases. Oftentimes we know the older we get, the greater likelihood we are to have a chronic condition. That could be congestive heart failure. That could be having macular degeneration. That could be asthma. I'm not 50 years old, and I know past medical history, I have a couple of things going on. But we need to understand, when it comes to these chronic conditions, there is no cure. There's only management. And this drifts back to the purpose. We need to be able to quickly, if we start seeing changes, get in front of our doctor. Let's demystify this a little bit. If you go down to your basement and you look at the floor and there's a big puddle in the middle of it, and then you look up and you see drip, drip, drip coming from one of the pipes, you're not going to call the plumber in 2 weeks. Let me see how this goes. Because you know there's going to be water up to your ankles if you don't. The same thing needs to be, if we start seeing changes in ourselves or our loved ones, call that doctor like what we would with a plumber. Some of the most common chronic conditions are heart disease, diabetes, and cancer. We can go on for several, but what these affect are our 4 pillars of ourself: our mind, our body, our spirit, and our soul. Those hold us up. If there's a problem with one physically, our mind is going to try to compensate, our spirit. But we need to be able to acknowledge this and not just let some of the anxiety permeate in our mind. Another loaded question. Is there anybody here that doesn't have stress? All of us have different stress. When we have stress, it oftentimes exacerbates some of the conditions that we're battling with. And again, the body homeostasis, mind, body, spirit, soul, when there's challenges with one, it's going to affect the other, because when we are stressed, our body releases the hormone cortisol. Cortisol causes inflammation that affects our arteries, that can affect arthritis. We need to steer into things and not just say things are fine. My kids tell me all the time, Dad, enough with the crusty dad jokes. The word fine is the original 4-letter word. Fine means I'm going out to physical therapy today and it's a cold, rainy day and I'm just moving slowly. Fine means I'm on the floor and I'm moving things around and I don't think I broke anything. Don't use the word fine when you talk to your doctor. Make sure things are in technicolor so everybody understands what is said, what it's meant, and why, how it applies to them and us now. Why are we here today talking about advanced care planning? Well, we tried it without having these discussions going back for many, many years, up until 2000, when Jersey was really called out on the carpet. In early 2000s, New Jersey was rated worst in excessive ICU, intensive care visits in the last 6 months of life, and also ranked worst with the last 6 months of quality of life in the United States. Those are things that we don't want to brag about. Because of those dismal statistics, New Jersey started the New Jersey Health Association for Quality and Patient Safety. It was born then. But its purpose and role was to develop educational materials, programs that, again, Kara is going to share with you that I passed on. Today's conversation by no means is going to be able to say, I got it, now I'm going. It's starting to let your mind marinate on some hard conversations. This is phase 1, and if I had platinum stars for all of you showing up and listening to me, I would give that, and thank you. Its role is to be able to implement policy so that healthcare providers have the tools to be able to better serve their patients. Create a statewide form, the PULST, Practitioner's Order for Life-Sustaining Treatment. We're going to talk more about that in depth in a little bit. And again, be able to make sure and educate the general public so that their voice is heard. The goals of care conversation is that spark to be able to start these conversations with our family or whoever is in our circle of influence. If there's people that I know, I like, I trust, that I think they know, let's make sure they have the tools and really have these hard conversations to make sure that they know exactly what you think they know. Being able to be an informed healthcare consumer, being able to talk about the conversation of your life. This is an opportunity. And again, this is going to be something that Kara will send out to you, that Nightingale is a proud supporter and sponsor of throughout New Jersey, to be able to take a deeper dive for different things. And even still, 23 years later, 24 years later, excuse me, only 20 to 25% of New Jersey residents have estate planning in place and advance directives in place. We need to do better, because the only thing worse than having hard conversations like this and with our families is now we're stuck in crisis mode, because there's not, let my mind think on this. It's what do we do now? Because again, optimally, they might ask, and oftentimes they need to have that decision, or worse, that decision has already been made, having the conversations up front. Gone are the days that we had the old school doctor. You know, I'm still a fan of Dr. Oz before the wheels got a little bit wobbly on him. That was a gentleman that knew people's answers before they even had the questions. But again, we had the primary doctor that brought you into the world, took care of you in your adolescence, took care of you in your adulthood, and flipped over, by the way, now this is my baby, can you take care of them? Healthcare doesn't work like that anymore. There's hospitalists that your primary doctor may not have access going to the hospital. You have your cardiologist, the pulmonologist, all these different doctors. We need to make sure that you sit down and have these hard conversations so that that doctor really understands, and you have that conversation with them about what's most important to you. What are some of those words that define a good doctor? Patient, kind, a good listener, helps me understand. What does that all drift back to? They're a good communicator. They're able to process and they're able to send information so that you know your voice is heard. Even if that doctor is that, there's going to be limitations. We need to have forms that support that. I'm a big fan that everyone should have a wing person go to their doctor's appointments. It has very little to do with someone's cognition, their intelligence, their educational status. It all has to do with where they are emotionally when we're having hard conversations with our doctors. Remember, I call it the Charlie Brown moment. Remember in Peanuts that those kids had sometimes pretty deep conversations with one another. But when an adult came in the room, what did they hear? Wah, 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 wah. Once you get that point of my emotional threshold has been met, it's awfully hard, because then the doctor says, is there anything you want to talk about before you go? And we say, what's the F word? I'm fine. But when you pull out of the driveway, that's when the avalanche happens. Bring someone there to make sure that the notes are taken. Play devil's advocate, making sure that someone that knows you represents and make sure that doctor knows what's going on with you, not just in the office, but where you spend most of your time. When you make the conversations with the doctors, again, we want to make sure that there's people there. And why does the doctor think that these are certain decisions, making decisions with the doctor? Does that doctor know what I'm dealing with? I'm a caregiver for my spouse. There's a set of stairs going on. Be honest with them. Don't tell them what you think. If I sit down and I have 3 glasses of wine, don't tell them that I have 1 glass of wine. Don't say my feet are fine when we know at the end of the day, I need to put my feet up because they're swollen and they're red, but they're cold to the touch. Let them know not just where you are optimally, but at your lowest level, so they know exactly what's going on. Ask lots of questions. Why does that doctor think this is that specific diagnosis? Have they treated someone with this diagnosis that also have my other diagnoses? Where am I now? What is this going to look like in the future? If your head, your heart, your gut's telling you this is a lot, I'm not really sure, we have the right for a second opinion. Don't go back to that same practice for a second opinion when we know the list of doctors, the second opinion's name is 4 down versus the doctor that you saw, because no youngling doctor is going to change the decision of the higher up doctor. Go to a different practice, but make sure that your insurance does cover that. So again, we are informed healthcare consumer. Going on, what is that doctor's definition of a successful treatment? Is that consistent with your own definition of a successful treatment? If these treatments that doctor is offering isn't palatable to you, it's okay to ask questions. What sort of alternative questions are there? Are there any non-traditional treatments? Are there any experimental? And what does that look like? And where can I go? Again, let's demystify things. The last time we bought a car, I'm confident none of us went on a lot saying, I want a red one. What did we do? We did research. We wanted to make sure what brand had the best gas mileage, what brand had the best safety. We need to do our due diligence because cars are expensive. We're priceless. And our loved ones, whoever we're around, are as well. Ask the questions. Be that informed healthcare consumer. Once you have that loaded question, don't leave the doctor's office saying, I'm fine. Again, the F word. Hate that word. If there's something new at play, I have had a lot of information thrown at me. Where can you turn me so I can gather more information that you trust is a worthy source for me to be able to let my thoughts marinate, for me to come up with a breath, for me to be able to talk to my family about that? I've done this for over 20 years. I am confident I will look you all in the eyes and say, there has never been a doctor that has ever said, thank God there's WebMD, because woo, that makes my life so much easier and my patients are better served. There's a reason why our doctors go to school as long as they do, because none of us is written like what WebMD is. It's written like a one-trick pony. None of us. If you have other things going on, that has a skewed perception for us to gather what that information is. That doctor, we need to make sure, is the correct mouthpiece that we're getting our information, so we trust them. Because when you go online, there is so much spam and questionable validity. 4 out of 5 doctors. Who cares? 4 out of 5 doctors. Where is their source? And I'll share a personal study with me. This came out probably 8 years ago. I'm reading this. A man's beard has 5 times the volume germs as a dog's mouth. My poor wife, and me. I'm like, okay, Kellogg, practice what you preach. Read all the way down. Sponsored by Puro Inc. What is Puro Inc? Puro Inc. is the parent company of Barbasol. Barbasol is the man's shaving cream. Of course they want you to shave. It's sketchy. The information you gather, you want to make sure it's clear, it's unbiased. So go to someone that's in the system and You trust them that they will give you that information. Once you have that information, again, sometimes these conversations are hard. Oftentimes what I do for the elders that I serve is to go wish game. It's a card game that's an example. On the back of every single card, there's a statement. It goes from very generic to pretty in-depth, that all has its fingerprints directly related to the 4 pillars of ourselves: mind, body, spirit, soul. Everything needs to be nurtured. That exercise is going to be breaking those cards into 3 different categories, making sure that what's most important, what's somewhat important, and what's not important. Once you have that information, that's a gift that then we can start having some really good conversations with our doctors and potentially other healthcare providers or attorneys to be able to get some of your thoughts, wishes, hopes, and expectations be documented. Making sure that everybody has your health proxy, power of attorney, living will, last will, and guardianship. I'm not even going to talk about trusts because, A, I'm not an attorney. I'm a social worker. I want to make sure everyone's voice is heard so they have their power, control, dignity, and peace of mind. Got to stay in my wheelhouse, but that's another component to have a discussion with an attorney. Let's break this down a little bit. A health proxy is a person that you nominate to make medical decisions for you if or when that time ever comes. If I nominate my son, who is over the age of 18, to make medical decisions, that doesn't mean that the doctors are going to start calling him instead of consulting me. That only comes into play if there's something that happens that I become incapacitated, that I'm not able to answer correctly, or if I'm unconscious. We need to make sure that if you name someone, they know you've named them. I've had another family member name me as their healthcare proxy after their daughter. Couldn't get in touch with the daughter. There was a change of status. I had a nurse from Robert Wood Johnson call me Chris, the nurse I've known for several years. You have so-and-so. I was thinking one of our elders were in the hospital. No, it's your aunt. I wish she let me know that. Tell them, sit down with them, have the hard conversations, because it's better before you name them. Some people aren't comfortable naming your brother. If you're 85 and they're 80, is that the right person? Because they might have medical challenges too. If you've had your advanced directives done, living will, health proxy, power of attorney done, but it's 10 years ago, it's worth going back to that attorney, having things be freshened up. Relationships change. Technology has changed. Making sure that the verbiage is appropriate to what they're dealing with now. Power of attorney. Power of attorney is similar to a health proxy that can make medical decisions. The power of attorney is a person that can move finances around to make sure that if you need to go to an assisted living or to have home care, they can move your money so that there's resources to pay for your care. Just because you have one does not mean they can do both. And again, making sure that they're comfortable, you naming them, and they're trustworthy and having hard conversations now ahead of time. A living will is a list of instructions of certain things I want and certain things I don't want if I ever get incapacitated. Under certain circumstances, I may not want to have CPR, resuscitations. Under certain circumstances, I may not want to have ventilation put in. That's not the end. It doesn't mean that you don't need to have a living will, but we need to start asking ourselves, training ourselves, and what? If something was to happen, and what? And we're going to get to that and what in a moment. Your last will. Your last will is different from your living will. Last will is once you're no longer with us, who gets what? the finances, being able to get the grandfather clock that's been in our family for 3 generations, making sure that that's done and that you eyeball that what you wished for 5 years ago, those people are still there and you still have those same relationships. We have all of these things because we want to avoid guardianship. The only person that wins in guardianships are attorneys because it's really, really expensive to have to go through the court system to have someone named. If 2 doctors name a person to be incapacitated, meaning that they're not able to make their own decisions, they are stripped of their rights and they are placed through oftentimes a person that's willing to come forward or through a county that has guardians through public guardian, or there's volunteer guardian, which I'm a proud vice president of, that people volunteer. There's screening that are named for guardianship, and then there's board members, nurses, social workers, attorneys, wealth managers that support that person to make sure that they have all the tools they need. So it's one-on-one versus a social worker that could have 30 different wards that they need to try to support. In New Jersey, you don't need to go through an attorney to have a health proxy or like a living will. There's different alternatives. The 5 Wishes is very well known. It's written by Mr. Jim Tully. This is Jim and I had the privilege of speaking with him at a COIL meeting before the pandemic, much more gray hair than I have the white hair now. I have a man crush on him. He's a genius, making things very clear, making things in less jargony speech, making things so if it's important to you, you can circle it, crossing things out that's not important, contrary to what you want. Being able to have things named, people named as a health proxy, and this can be honored. It's just important for all of the documents we're going to talk about. They need to be present at the time of the emergency, or they can't be honored. Another great program or service out there is the 4-step eye care plan. That's another document that I'm sending over. The 5 Wishes I did not send over because I don't have copyrights, and you can go on Amazon and it's like $5 to be able to get that. The 4-step eye care plan is free, and I'm sending links over to Kara that you'll be able to look and identify with some of these. Again, it talks to you about what do you know about a diagnosis, one of your diagnoses, all of your diagnoses. What are your prognoses of that diagnosis now and also in the future? What are your goals of care? I like that, much like your homework, because it all drifts back to being able to make sure that the direction of your healthcare is going in the direction that we so choose. What's most important? Focusing on life, not the disorder. It talks about what palliative care is. With palliative care, you have a standalone different doctor that you can continue to see all your specialists. Go to the cardiologist, go to the pulmonologist, and be able to use them as a sounding board to make sure that this is my ultimate goal. Where are we going? If there's a new path with a change of my status, how does that reflect? And that doctor is able to guide you, because sometimes what has worked so long with the options that were available, there might come a time that those options are no longer working. Where are we going from the philosophy of treat and cure versus comfort? Someone comes to me and says, I have a diagnosis of end-stage lung cancer. Going back and forth to the doctor, we might want to say, because just going there could be really, really hard. The risk-benefit ratio. What about hospice? So that someone is making sure that their comfort measures are being available, that there's medications there. so that if there is a change of status, they're going to be comfortable. Because when things change and they can change quickly, there's not a lot of time for emergency medical squad people to do an assessment of, this is my 30-page living will. What's consistent with that? They're never going to go in there. They are trained to do everything they can do to save you. They're going to throw the kitchen sink, doing the compressions, doing the ventilation, doing whatever it takes to be able to get you back to the emergency room. And the doctors and the nurses there are going to do everything. Sometimes in a person's journey, trying to have everything done could be contrary to what they want. Again, there's no personal preference. It's where we are right now. Sometimes the treatments are more challenging. And when that time comes, we need to be able to talk about what the POLST is. And this is the Practitioner's Order for Life-Sustaining Treatment. And again, you have that. I sent that over with Kara for you to be able to look at. The POLST is different from a living will that says under certain circumstances, certain things are done. A POLST is actionable. It says if something happens right now, this is what I want. It's in your handwriting and there's a doctor's order attached. If you've gone to a subacute or a nursing home, you can see the big med carts that the nurses push around to make sure that everyone gets their medications. There is enough drugs in there to drug a bull moose. But without a doctor saying, if Mrs. Smith has a headache, give her Tylenol, the nurses can't do that. This is the same thing. If something was to happen now, there's orders here that are curtailed to your hopes, wishes, and expectations. We can talk about, again, the POLST is different than sometimes this develops a change of status in the hospital. They're in hospital and out of hospital do not resuscitate orders. Those forms only talk about compressions and your CPR and resuscitation. It doesn't talk about intubation, having a tube go down. It doesn't talk about if you want to have antibiotics or dialysis. And these are hard conversations. The POLST is something that's going to be able to encompass all of your hopes and wishes at that time. So it doesn't need to be said over and over. Like if there was a hospital order and you go to a rehab, you're going to need to have these same conversations again. There's a reason why the POLST is green. It doesn't blur with the other pieces of paper. It stands out and healthcare providers know to go to that first. Who deserves a POLST? Who needs a POLST? Anyone that has strong feelings of how they want to be treated at end of life. I ask people, if something was to happen right now, what do you want to do? If you, God forbid, your heart or your lungs stop right now, they come back to me and say, Chris, I'm not looking to go anywhere, but if the good Lord calls me, I want to be comfortable. I don't want things done. I don't want tubes in. If you have strong feelings right now, I need you to be able to have a conversation with your doctor. Where does your hopes, wishes, and expectations fit into that doctor's perspective? Being able to get that form completed by your primary doctor. When you have this conversation, I am a fan. Talk it through with your family first. This is something that I'm talking about. This is what I'm thinking about. So you are an informed healthcare consumer. So it's not surprising them. Making sure that when you go in there, you call and say, I don't want just a well visit. You're specifically wanting to have a conversation about the POLST, Practitioner for Physician's Order for Life-Sustaining Treatment. There's a different billing component for the doctor, and they will also be able to give you more time. Because anybody want to take a guess what the average time in Jersey we get to spend face-to-face with our doctors? Again, another quick question. 7 minutes.
Oh.
7 minutes. This conversation, we're worth more than 7 minutes. Let's come in with what we feel is what we want, and then making sure that doctor concurs, educates us, clarifies, and then signs off. And then this form needs to be where we are when this goes down, because it can't be honored like the other ones if it's not present at that time of the emergency. Let's talk about some of the pulse specifiers, what make it so powerful. I'm going to go back to the homework of not just what you want on that piece of paper. Once you're done writing that, I want you to flip it over. On the other side, I want you to start thinking about, what don't I want to have happen to me? What keeps me up at night? That's what I need you to write down in one sentence there, because that homework should be able to really give nice handles for you, your family, and your physicians to guide the very first thing that we're going to talk about now, which are, again, the goals of care. What's most important? Oftentimes I hear having meaningful conversations with my loved one, being able to be out of pain, not going to the hospital, to stay comfortable. There's no right or wrong answers for any of this. And that's what makes us unique and makes us human. But we need to make sure when that time comes, everyone around us in our circle of influence knows, they're comfortable with, and they're willing to support us and our 4 pillars, what we talked about earlier. Section B, again, talks about medical interventions. Do we want full treatment? We're going to get full treatment if we don't ask for it. That's just a given. But sometimes we want to have limited treatment. What does that look like? Do I still want to have IVs or feeding tubes? What does that look like? Do I want to have symptom treatment only? Meaning having all of these evasive tests when I feel like there's been a baseline of the doctor says there's only so much more I can do. Let's make sure, again, it's not curative. We're getting closer to that comfort. And where can that be comfort? Where can that comfort be given where I am now? Section C talks about artificially administered fluids and nutrition, talking about IVs, talking about feeding tubes. Yes, no, or are we going to try for a trial for a period of time and reconsider? Dehydration and artificial nutrition is very, very hard, because when we make food for our loved ones, it's not just bodily nourishment, it's also affection that we give. But end of life, people, their body is determining what they can and what they can't accept. It's up to us to re-educate ourselves on what should be best for them. If they're offering or if they're requesting their favorite food, let's give it to them. What sort of precautions are there if there's different restrictions on swallowing? To talk about aspirations, what does that look like? Because I've heard before people say, Chris, my husband has end-stage cancer. I don't want him to be able to have to die because of dehydration. At end stage, people should be more dehydrated, because if you're fully hydrated, you're going to have secretions. You're not going to be able to breathe in and out easily. You're not going to have the ability to go to be able to expectorate. Being an informed consumer, what does that look like? And ask hard questions now to the people that you trust to be able to make you an informed healthcare consumer. Section D talks about cardiopulmonary resuscitation and airway management. Again, do I want to have a do not resuscitate right now? Am I going to try to get things started? Because without this, people automatically, that's what we do. But there might be a time that people don't want that. Also talking about airway management. Are we talking about mechanical ventilation? Or are we talking about oxygen? Having the little nasal cannula there, making sure we're keeping our pulse ox, the volume of oxygen in our blood up. Or are we talking about a BiPAP? It's the mask that when we breathe in, it forces oxygen, pure oxygen up, so it really boosts the pulse ox level for us. Or a CPAP. A CPAP, instead of waiting for us to breathe in, it's forcing oxygen continuously to try to keep that up. Neither one of those three things are considered invasive. Being able to have the tube go down, that is. And this is what the doctor will discuss and what is acceptable and what is not acceptable. Again, Section E talks about who can modify decisions for me. Sometimes there's different family dynamics. People love me. They're not ready to let me go, but I want this. If there is a person that is going to not value your wishes, hopes, and expectations, make sure that that person is not the health proxy that can honor that, and just make sure the people that can are willing and wanting and able to do that. Section E will talk about the person that you name to make medical decisions for me, and you want to make sure it is consistent with what you've done. Because again, whatever you've done most recently will supersede what's done before with an attorney. There's a section on the pulse that says, does my representative have the right to alter my pulse if the time comes that I'm not able to do this myself? That's something there that's intended for you to be able to make sure that your wishes are always honored. Again, Section F talks about who signs it. Once this is reviewed by you, you can fill all this out by yourself. It's not empowered until you have that doctor's signature with all of that doctor's information that has his authorization and serial number. You want to make sure that the person's name is written on there for you, who is your healthcare representative. Also talks about anatomical donations. People often say, oh, I want to donate. That is fine, whatever you would like to do, but there is more to that than just saying that. Do we know that where are our bodies being donated to? And there's only two in New Jersey that are: the Rutgers, New Jersey Medical School of Anatomical Associates, and then Mercer County Community College Funeral Services donor program. If you have strong feelings, let's try to be able to take the deeper dive so that the people that are around when we're not there, they know what we want and have the handles to be able to get you there. We're going to talk about something now that is a little bit more taboo, but this goes back into our toolbox. We have a lot of tools. Doesn't mean that we use them all. I'm not encouraging or discouraging, but this is something that people should be aware of that is an option, and that's the Medical Aid in Dying Act. This was done in August 2019. The Medical Aid in Dying Act is a program that permits qualified terminally ill persons and attending doctors to write prescriptions for a medication that would end that person's life. Only a few physicians and even less pharmacies dispense this medication in New Jersey. The terminally ill person must be in a terminal stage of an irreversible, fatal illness, disease, or condition that prognosis is based on a reasonable medical clarity that the person's life expectancy is less than 6 months. The requirements are as follows. The terminal ill person must be a New Jersey resident. The patient has full capacity to make their own decisions, communicate them to the attending doctor, plus be able to administer the medication themselves. A health proxy can't do this for a person. Only an alert and oriented person like we all right here would be able to make these arrangements. The patient has full capacity to make their own decisions. The consulting doctor must confirm with attending doctors and records. So again, once they have that one conversation with the first doctor, that patient needs to go to another doctor to reconfirm that first doctor's conclusions that that person has a terminal illness. The patient must orally say they wish for the medical aid in dying. that patient needs to sign a letter and has 2 witnesses that are capable of acting and voluntarily wish that medical aid in dying is confirmed. This is all done in front of that doctor at that time, and that doctor is watching that patient sign in front of them. The patient must say to that doctor, "This is what I wish for." After that consulting doctor's appointment, that patient again must go to an attending doctor for that second appointment. And once that second appointment is done, that patient and family member needs to go back to that attending doctor one more time. And that doctor must ask that question, "Do you wish to have the medical aid in dying?" And that patient must say, "Yes, I do." That discussion for the second appointment needs to happen on day 15 from the original appointment with that doctor. So it's 3 steps: original conversation, the doctor follow-up confirming that diagnosis that would qualify, and then going back to that attending doctor who was the first doctor. And that doctor again asks, "Do you still want to participate in medical aid in dying?" It's only then that doctor gives the prescription to the patient to be able to go and have that prescription be filled. Why are we talking about all of this? Because much like we don't talk about this with our doctors, and we assume, we don't talk about this sort of stuff with our family, who we love. There was a study done in 2016 with the sandwich generation, people like me that are raising small children and having older loved ones. 54% of us, the sandwich generation, would rather talk to our children about the birds and the bees than talk to our parents about the future care needs. 55% of them have no plans. It's up to the older generation. You taught us how to drive a bike, how to drive a car. Your education of us is not done. And that's not just beneficial for you, it's beneficial for our generation. A Genworth study done in about 8 years ago shared that 72% of adult kids feel that their parents should have a detailed conversation with them about their future care needs. Only 69% of those parents feel that they've had that conversation, that clear conversation. "Oh, we've already did." But when it comes back to them, only 52% of that sandwich generation says it wasn't clear. It wasn't detailed. "I don't know what you would want. We don't have the tools we need to honor your wishes." But once that detailed conversation did happen, 93% of those adult children had peace of mind, and 95% of the older adults had peace of mind. What do we all want at the end of the day? We want our power, control, dignity, and peace of mind now and for the future, and for our loved ones. It behooves all of us to be able to have the hard conversations so we can have it in a timely manner, but be able to educate ourselves and then rally the resources necessary to have your mature life plan in place. My name is Chris Kellogg. I threw a tremendous amount of information at you. Thank you so much for your patience, and I'm available for questions.
That was excellent, Chris. Thank you so much. And it was a wealth of information, and you have a wealth of knowledge in your brain. And I am very grateful, along with everyone else, I'm sure, on this call, for you sharing some of what you've learned over the last 20 plus years. So now we're going to move into our question and answer section. Just so we don't talk over one another, if you do have a question you'd like to ask live, raise your hand and I'll call on you. I'm just going to check the chat room first. I do see something from Gladys about euthanasia. I know that you touched on that in your medical aid and dying slides. But Gladys, did you have anything further you wanted Chris to touch on at this time?
No, thank you.
Okay, great, excellent. Is there anyone else that has a question at this time? And just know too, if it's something you want to talk to Chris with offline, I'll be sending his contact information to you via email. All right, Tom, you have a question? Just make sure you're not on mute, Tom.
Hello?
There you go.
Hi, Tom.
Okay. Hi, how you doing, Chris?
I'm well, thank
Uh,
you.
Regarding the pulse, should each of our doctors have a copy of the green copy of the document as versus a gray copy, if you will? That's what happens when you copy it. Is there any reason for any other doctor to approve of it other than our principal uh, health giver?
I say yes, because I would rather always be redundant than talking with our primary doctors, our cardiologists, our pulmonologists. Make sure they know what my goals are, because they might be thinking, again, going back to what is our definition of a quality of life and what is that doctor's definition of a successful treatment and outcome.
Okay, is a gray copy legal?
You can do that. It still can be honored, but honestly, I have the habit of, once it's available, going out for a couple bucks, you can get a thin ream of light colored green paper, and it does pop. To answer your question, yes, white paper, it's still honored, but I am that guy that would rather measure twice, cut once.
Very good. I have one more question that's kind of vague, but you hear these situations where a team of doctors at the hospital must approve any kind of major change. You know, such as the care plan and such as the MAID plan. Can they override it?
So that's a very good question, and I'm trying to give you as clean cut as possible. We have rights to be able to request different doctors when we are in there. The primary doctor when we're in the emergency room or the hospital is the hospitalist. We have rights if the cardiologist hypothetically is steering us down one path that it's not what I would want. My voice is not being heard. We have the right to say, I would like to consult again, being able to consult a doctor with the palliative. You will get a consultation with a palliative doctor, because that palliative doctor is essentially going to be able to weigh and have that conversation with the cardiologist and the hospitalist and listen to you, but also advocate. Has that answer been
Yes, sir. One other
beneficial?
question, please, Chris.
Of course.
How enforceable is the New Jersey Pulse out of state if I'm on vacation, traveling, etc.?
Very, very good question. It is honored. However, much like we can go online in New Jersey, and I'm going to be spending a period of time with my kids in New York City. If this is something that you really feel strongly about, you can go online in New York's form. Instead of practitioner's order for life-sustaining treatment, theirs is the most medical orders for life-sustaining treatment, and have that doctor sign that. But for shorter times, that is honored, because again, that doctor's order is attached. I would be more inclined to say, if you're going to go live in New York, that's something that we need to revisit and reconfirm with your, specifically your new attending doctor over there.
Thank you.
You're very welcome, sir.
Any other questions at this time? Go ahead, Dottie. You're still on mute.
Can you hear me now?
You got it.
Okay.
Yes.
This is not really a question. It's kind of a very short little history. I had been or have been very interested in the whole death and dying, end of life situation for many, many years. And when my husband and I moved here, I came to this meeting. When did we have? A year ago or so, when Chris was here before. And I got the papers, and Alan and I had a difficult few days, discussing it. We discussed all of the questions, and we filled it out. Okay, deep breath time. And very unexpectedly, my husband collapsed in this past September. And it's a panic moment. It was during the night. He had gotten up to go to the bathroom and tripped and fell onto the bed, and I knew something was terribly wrong. And I called our own security, and then I also called 911. And there's a lot of stuff happening. And this is not an image, but something I had in my head. It wasn't completely, whew, now what do I do? We had planned, we had talked about this, and now suddenly my husband is barely breathing. And one of our local fellows, who was just wonderful, but he started CPR. They got my husband onto the floor and started CPR, vigorous. It was very frightening to watch. And I realized this is not what Alan wanted. And I got the green paper, which was on the refrigerator, and brought it over, and Alan had stopped breathing, and 911, the hospital people were there, and they hooked him up, and it was a flat line, which is a horrible thing to see. But this is what he wanted. And I have to be so thankful that I had that green paper, and that we had faced the situation and had discussed it calmly before, and it worked. And just as a funny side note, Tom, you can get green paper in the wonderful office of the housing department. I made a few they have green paper. They did it with a smile. And I made a few copies and sent them to our children who live in Denver and California, not able to be here in an emergency. And they kind of joked, and they said, "Hi, Ma, thanks for the great mail." But they agreed. And so it was good that they were on the same page. So I have nothing but good things to say about the Pulse program. And I've been I want to say kind of a little missionary with a few people say, come on, you got to do it, because you don't know when it's going to happen. I would never have thought on that day, September 16th, that my husband would be gone within a few hours. Never have thought that, but it happened. Then I have one other little commercial about the end. Something has to happen after the person dies. I used to laugh and say, I read that somewhere, we're all going to die. I think it's going to happen. And I also think you have to have a plan for that moment, what happens to your physical body. And I had been familiar with direct cremation, and I used that for my husband. And I'm not a paid spokesperson, but I will say out loud, it was APIRE. And if any of you who are listening would like to talk to me about that, it was a very, very compassionate, efficient, beautiful way to end that night. But I would be very happy to talk to you about it. I'm a resident at Heath Village, and I would be delighted to talk to you. That's all I got.
Dottie, thank you so much for sharing that. And it's hard, and get a little verklempt just listening to the story. We don't ever have that window coming in, but by being proactive and steering into things, again, optimal, possible, and problematic, we can have the tools in place. So sometimes there's hidden gifts, and you being as proactive with your husband, you were able to honor the wishes. So you did everything you could have done in a very challenging scenario, and my thoughts and prayers.
Thank you.
Go ahead, Melissa.
So just a couple things I want to respond to Dottie. I too, so on the flip side of what, Chris was talking about, talking to your kids, my mom and I had that conversation years ago. And like Dottie, I had a very tragic sudden passing, and like, forget 4 hours. I had I hugged her in 1 hour, and the next hour she was gone. But thankfully I did know what her wishes were, and I could tell them, similar to you, Dottie, stop doing what you're doing. That's not what she wanted. But I will tell you, one thing that no one told me is we all are so security conscious that we think these documents have meaning beyond to us. So you hide them, or you put them in a locked safe box or a firebox. They don't need to be hidden. Your living will, your POA, the POA is ineffective once that person passes away. So if you're the POA of someone, you can have that document out in plain sight because it's only applicable to you. And once the person passes, it's no longer useful. So I'm sitting there scurrying around looking for these documents that I thought I was doing the right thing by putting them away in a special place. But in a moment of an emergency and a kind of a tragic, heightened situation, you can't find them. So I just would encourage everyone to realize you don't have to hide them away. So the fact that you had on your refrigerator, we're so glad you do that, Dottie. And just as a word to any Heath Village residents, we also scan them into our database. So at any given time, we can access them for you. Even green documents that we can scan in color. So that's all I had to add.
That's an excellent point. Thank you for sharing your story too, Melissa. Are there any other questions for Chris? Okay. Well, again, I want to thank all of you for taking the time for joining us today. I'm sure this was an extremely meaningful and powerful presentation. Definitely for myself too, hit home, and I'm sure it has for all of you on the call. Again, I just want to recap. You will receive a follow-up email from myself. It'll be from kolson@heathvillage.com. And it'll have a link to this recording. It'll have Chris's PowerPoint slides so you can use as a reference. It'll have numerous supporting documents that Chris mentioned previously in his presentation that he just emailed to me this morning, and I'm going to include those. And I'll include information on Heath Village too, and you'll have Chris's contact information and my own. So if there are no other further questions, I'm going to stay on the call until I see everybody has exited before I end the call. Thank you again. Stay healthy, stay well. Have a great rest of your day.
I just want to
Well,
thank
everyone.
Kara. Before you sign off, I want to thank Kara for taking the lead on this. She did a great job, and I know it's something that's really valuable. So thank you very much, Kara.
Thank you, Kara.
Thank you, Chris, for your time too. You're amazing, honestly.
Yes,
Thank you.
thank you, Chris. So it's pretty funny. Dottie was talking about how she's been talking to the residents. The phone call that I got in the middle of it was someone that Dottie's been after, and she was talking to me about some of her planning that I know that Dottie specifically spoke with her about. So Dottie was telling the truth.
We do another program called Mature Life Planning that really breaks everything down. So if you'd ever want us to come back and talk about that, I'd be happy to do that as well. But again, we can plan for anything. It's the pivot that gets a little bit tricky when the planning's not done.
Yep. Thank you.